Hello, how are you? Welcome to another session on pneumothorax. In this video, we are going to focus on types and the causes of pneumothorax. My name is Winniebarawa. If you're new in this channel, we focus on lessons, lectures, and interviews relating to healthcare. If that's an area you really enjoy, don't forget to subscribe and give this video a like. Comment, and be with me all the way to the end. So let's introduce the common terms that are known to be related to pneumothorax. One of the terms is pneumothorax itself, which means accumulation of air in the pleural space. So the pleural space is the tissue lining that covers the lungs, and we have two types of pleural layers. We have the visceral and we have the parietal. And in between the visceral and the parietal layer, we have a pleural space in there. This space is expected to have a thin lining of mucus that is supposed to prevent friction and allow smooth movement of the lungs during inspiration and expiration. So, however, in some instances, this space can be occupied by air, leading to what we are calling pneumothorax. The other term we have is pneumothorax, which by definition is accumulation of blood in the pleural space. So in the instances where the pleural space is occupied with blood, we shall no longer describe that as pneumothorax, but rather we shall call it hemothorax. But you can have a state of hemopneumothorax, which is accumulation of both air and blood in the pleural space. Then we have fluidothorax, which is accumulation of any other form of fluid or matter in the pleural space. It could be tumor, it could be any other unknown substance that is in that space. We got also hemomediastinum. This is accumulation of blood in the mediastinum. The mediastinum is this area where the cardiac system is located or where the heart is located, and in some instances, we can have blood accumulating in that space. So here's an illustrated video, not video, sorry, but a picture of pneumothorax. And we are saying we have pleural space that is between parietal and the visceral. And in this pleural space, it can get occupied either with air or fluid, producing the aspect of pneumothorax or hemothorax. When this happens, the lungs get to be pushed due to the increase of pressure in these accumulated spaces, and it can end up getting collapse. So in some books, they'll be defining pneumothorax as a disease where there's collapsing of the lungs due to accumulation of air. So by definition, pneumothorax basically is the entry of air into the pleural cavity in which the lung is residing. And we are told each lung is located in a separate pleural cavity, and due to this, the pneumothorax of one pleural cavity may not cause collapse of the other lung. So like I've said, pneumothorax is an aspect where there's accumulation of air in the pleural space that leads to increase of pressure in this area, and it can lead to collapsing of these lungs. However, you need to appreciate that the pleural spaces are in two different chambers or in two different pleural cavities. And because they are in two separate pleural cavities, it does not mean in an instance where there is there's a collapsed lung, the other one will get affected. No. Most of the time have either a unilateral aspect of pneumothorax or bilateral. However, the unilateral pneumothorax is more common than the bilateral pneumothorax. Basically, we are saying you may not always expect that the lungs will collapse at the same time just because you've detected pneumothorax. It only affects the pleural cavity that has been affected or that has been injured. So we have different types of pneumothorax. There are three. And the first one here we have is the open or communicating pneumothorax. So open pneumothorax usually involves a traumatic chest wound leading to air entering the pleural cavity from the atmosphere. So here we have a wound, could be penetrating wound or gunshot wound, and this wound leads to an opening that allows air to enter from the environment or from the atmosphere. So it implies that there's an opening in the chest wall that is very large and allows air to pass freely in and out of the pleural cavity with each attempted respiration. So what happens is, because of this wound, the air enters into the pleural cavity, builds up the pressure in this pleural cavity, and tends to compress on the lungs, and they will collapse. So we are told the lung collapses in open communicating thorax due to equilibration of pressure within the pleural cavity with the atmospheric pressure. So when the air keeps coming inside here, because this is open and it's a large wound, air tends to come in and easily come out when you breathe out. So with the air coming in continuously, this lung can actually collapse due to the pressure buildup and the air buildup in this pleural space. However, we are told when the client breathes in, there's a way in which it compresses on the lungs. But when the client breathes out, that release of pressure tends to enable the lung to expire or to expand a little bit. But at the end of the day, you still can end up with a lung collapse. The second type of pneumothorax is the tension pneumothorax. So in tension pneumothorax, we are saying this is a condition where there's one-way movement of air into the pleural cavity, but there's no exit for the air. So it's a tensed entry method. The air gets in, but there's no escape route for this air to get out. So it's a condition where there's one-way movement of air into the pleural cavity, but there's no way out of the pleural cavity. Mostly, again, involves a hole or a wound onto the pleural cavity that allows the air to enter, but there's no area to exit. So how does it happen? In this tension pneumothorax, what happens is you could have a gunshot wound here that allows the air to go in, but there's some flaps of tissues that when the patient is expiring, it locks that entry point and the air does not escape. So the air builds up, increases the pressure around here, and it collapses these lungs very immediately. So upon expiration, we are told the hole or the opening closes, which prevents the movement of air back out of the pleural cavity. We treat tension pneumothorax to be a very life-threatening condition because the pressure in the pleural cavity normally continues to increase and can lead to further lung compression, leading to compression of the heart or even compression of major large blood vessels around the cardiovascular areas. So tension pneumothorax is an emergency and really need to intervene very fast to prevent compression of major organs or major blood vessels around the thorax. And the last type of pneumothorax is what we call the closed or spontaneous pneumothorax. So closed or spontaneous pneumothorax is where we say there's a sudden onset of air in the pleural space with deflation of the affected lung in the absence of trauma. So there's no trauma in this type of pneumothorax, there's no injury on the chest. However, it is due to air leakage from the lungs into the pleural cavity or into the pleural space. So you can observe in this diagram, so there's an injury directly on the lung such that when the client breathes in the air tends to escape through that injury on the lung. So we are told this injury on the lung that is causing the air leakage could be caused by factors like lung cancer, rupture, pulmonary diseases like fibrosis. And so with the lung having been damaged directly, when the client is breathing in, this air comes out. So the increase in the pulmonary pressure, in the pulmonary or the pleural pressure, prevents the lung expansion during inspiration and the lung can end up collapsing. So unlike the tension and the open pneumothorax where we have an injury on the walls of the chest, in the closed or in the spontaneous pneumothorax, we have a direct injury on the lungs. So that's the difference. The injury or the leakage is happening directly from the lungs. It's not due to entry from the atmosphere. So let's look at the difference. What is now the difference between the two? We're basically looking at open and tension pneumothorax because these are relating directly to the environment. So in the open and tension pneumothorax differentiation, open pneumothorax is described to be an aspect whereby air enters the chest during inspiration and the air is able to exit during expiration. So there can be some slight inflation of the affected lung due to the decrease of pressure as the air is moving out of the chest. So like I've said in the open before, there's that large hole of wound on the chest, and so the air is able to get in when the client is inspiring, and part of the air can get out when the patient is breathing out because of the pressure release. But in the tension pneumothorax, we are told the air can only enter, but it cannot leave the chest. So as this pressure is building up in the chest because of the one-way movement, the heart and the great blood vessels around the heart gets to be compressed, and also there's a shift of the organs around that particular mediastinal area. So one of the organs that ends up getting deviated is the trachea. So we are told in the tension pneumothorax, there's observable structure deviations, and that is the trachea deviation, whereby the trachea is usually pushed from its normal midline position towards the opposite side of the chest of the unaffected lung. So you see that if the left lung is the one that has been affected, then we will tend to push the trachea towards the right side of the body. The other bit is there's a risk of compressing major blood vessels, and there's also a risk of compressing the heart and other organs relating to it. So opening pneumothorax or open pneumothorax is a little bit accommodative, whereby the air can come in and it can come out during the respiration cycles. But in the tension pneumothorax, there's no exit of this air. However, there's very quick buildup of pressure that tends to compress on the organs around this area, including now tracheal deviation and producing other aspects of chest compressions on the heart and the major blood vessels. So here is a good illustration. So in open pneumothorax, there is easy entry of air, but during expiration, there'll be exit of this air also, part of it. So this lung will be compressed as it's coming in, but it will have some ability to expand when this air is coming out. Now, in the closed pneumothorax, this one we already described it that there is only air escaping directly from the lung due to the injury, but our key focus is the tension pneumothorax here. That you're saying in the tension pneumothorax, there's one-way entry of air and the air is not coming out. So because the air is not coming out, this is treated as an emergency because it can very quickly lead to collapsing of this lung, but the pressure also here builds up very, very fast. And so it has a very major effect of collapsing the lungs, but it also tends to compress on other organs around it. So it ends up compressing on the heart and pushing it into the area that is not affected, but also there'll be deviation of the trachea towards the area that is not affected. So it will be deviated away from the midline. And this brings us now into what are the causes of pneumothorax. So we are told pneumothorax could be primary caused, that is no underlying lung pathology, but can have a sudden onset of this pneumothorax with no known lung pathology. However, in the secondary pneumothorax, most of the time we relate it to connective tissue disorders like cases of lung fibrosis where the lung can have a weakness and it can perforate and start releasing aspect of lung leakage. Can also have lung diseases, chronic TB, lung fibrosis, and malignant. So these diseases around our respiratory system can basically lead to an opening that can allow air to enter directly from the environment, or it can allow air leakage from the lung tissue itself. Then the other bit is iatrogenic. Iatrogenic causes, these are causes due to invasive procedures, which could be examples like surgery. So during surgery, you can have lung tissue injuries that can cause air leakage, or you can have chest wall damages that can cause openings and allow air to come in from the atmosphere. But you can also have thoracotomies and lung biopsies. All these are possible procedures that can damage the area around the respiratory organs and lead to further entry of air into this space. But you can also have injuries and trauma in form of either blunt injuries or penetrating injuries that can cause entry of air directly through the chest or indirectly through the lung tissues damage that allows the air to leak out. And this brings us to what is the pathophysiology of pneumothorax. So the biggest pathophysiology is the air leakage due to the trauma or due to the underlying cause. And due to this, there is air buildup in the pleural cavity caused by a hole in the chest wall or in the lung tissue directly. So this air causes pressure in the lung to build up that can lead to the lung collapse. So the biggest worry with pneumothorax is basically the lung collapse, which is due to buildup of air in the pleural space, as you can see here. And this building up of air causes increasing pressure that can compress on the lungs and can cause it to collapse. That's basically how you can summarize it. Or if you love the long descriptions, then you can talk about air leakage or air entry into the pleural space that builds up on its capacities and increases the blood pressure and increases the lung pressure. This increase in the pleural pressure tends to now compress on the lungs and they can end up collapsing. And that brings us to the first part of the description of the disease pneumothorax. Don't forget to watch the coming video that will describe further when it comes now to the clinical manifestation, when it comes to the management and the possible complications of pneumothorax. Thank you for staying all the way with me to the end. So watch out for the next video on pneumothorax. Bye bye and see you.